evening and welcome to my presentation on an approach to the pediatric ECG. My name is Tamyan Joseph. I'm a medical officer in the emergency department at Rahima Musa Mother and Child Hospital. I am by no means an ECG guru, but I would like to share with you the little bit of ECG knowledge that I do have. So ECGs can be fun to look at, right? A little bit like looking at abstract art that hangs in a fancy museum. Their beauty is often in the eye of the beholder. That being said, they are a vital tool in clinical medicine if they can be interpreted correctly. There are several situations when the pediatric ECG is an integral part of the clinical evaluation. Such conditions include, and is not limited to, syncopal episodes, drownings, seizures, pericarditis, and chest pain. So ECGs are definitely more commonly encountered when evaluating adult patients. And I think it's for this reason that the pediatric ECG can make doctors feel very uncomfortable. So just a little cartoon there. So when we perform an ECG, it is critical that we place the electrodes in the correct places on the patient's body so that we can get the best representation on what is happening in the heart. The leads are placed on the arms, legs, and across the chest. I'm not going to go into much detail here. I think this is something that you can look up in your own time, but as a brief summary, the limb leads are placed on top of the arms or legs where there's less muscle interference. And then the precordial leads are placed across the chest. V1 is placed in the fourth intercostal space, right sternal border. V2, fourth intercostal space, left sternal border. V4 is placed in the fifth intercostal space, mid-clavicular line on the left side. V3 is placed midway between V2 and V4. V5 is placed in the anterior axillary line, the same horizontal plane as V4. And then V6 is placed in the mid-axillary line, same horizontal plane as V4. So the ECG leads and what they mean. So let's quickly review the leads used in a 12-lead ECG. The electrical forces of the heart in the frontal plane are detected by the 6 limb leads, which are labeled 1, 2, 3, AVR, AVL, and AVF. The frontal plane is the vertical plane that divides the body into anterior and posterior portions. The precordial leads are labeled V1 to V6. They capture the electrical forces of the heart in the horizontal plane. The horizontal plane is the imaginary plane that divides the body into superior and inferior portions and is perpendicular to the frontal plane. On the bottom of the recording of an ECG is the rhythm strip, which is a continuous recording of lead 2. In young children, the right ventricle normally extends to the right side of the sternum. To appropriately display right ventricular potentials, ECGs for children in the under 5-year age group must include additional leads, such as V3R, V4R, and that is placed on the right side of the chest at the point analogous to the left-sided V3 and V4. So as you can see here on this diagram, V4R is placed in the fifth intercostal space, right mid-clavicular line, and remember to label it on the ECG that it is V4R. V3R is placed between V1 and V4R. So a stepwise approach to the pediatric ECG. Now that we know where to place the electrodes on the patient, let us have a closer look at how to interpret those squiggles that come out on the ECG paper. The aim of this presentation is to help you to identify what a normal pediatric ECG looks like so that you are able to identify which pediatric patients might need further investigations. So it's basically all about pattern recognition. If only it was really that simple, right? So this is a standard 12-lead ECG for an adult. This is a normal pediatric ECG. It looks quite different to the adult one, right? Way more lines and squiggles. So it's very important that we understand which leads look at which part of the heart. Leads 1, AVL, V5, and V6 cover the left lateral part of the heart. Leads AVR, V3R, and V4R cover the anterior right side of the heart. Leads 2, 3, and AVF are classically known as the inferior leads. The remainder of the leads are known as anterior leads since that they sit on the surface of the chest. Leads V1 and V2 are physically placed on either side of the sternum, and thus they also give us a better understanding of how the septum depolarizes inside the heart, specifically the atrial septum and the ventricular septum. So when you read, you begin with A, B, Cs. When you look at ECGs, you begin with a systematic approach. So let's see if this approach can make looking at an ECG a slightly less daunting task. Having a systematic approach to any ECG will help you to stay organized and competent when interpreting ECGs, so that you can correctly interpret them every time. The basic approach to any ECG, be it an adult or a pediatric patient, consists of the details of the patient and the details of the ECG machine, the rate, the rhythm, the axis, the intervals, voltages, and repolarization. The pediatric ECG, as the pediatric patient grows up, will change. In order to get a better understanding of this and to make sure that you interpret the ECG correctly, you will need to understand what normal values are for the certain pediatric age groups. We will look into these in more detail in the upcoming slides. So the first step in our approach is to check the identification and the calibration. This information can be found at the top of the ECG. It is extremely important to make note of the age of the patient, especially in pediatric patients, as you need to use age-appropriate norms for all pediatric ECGs. The calibration for speed and voltage can be found at the beginning or at the end of each row. In standard calibration, each 10 millimeter upward deflection in the recording represents 1 millivolt, and each 25 millimeter in the x-axis represents 1 second. If adjustments have been made to these standard calibration settings, it will affect how you will interpret the ECG pattern.
An ECG is normally performed at a paper speed of 25 millimeters per second. This means that each small box on the ECG is 40 milliseconds in duration. In terms of the amplitude, the ECG is performed at 10 millimeters per millivolt. This refers to the size of the deflection on the ECG. It can normally be found on the bottom part of the page or can also be seen on the scale on the left-hand side. You can see that this rectangle is 10 squares high, which corresponds to 10 millimeters per millivolt. You should always ensure that this is done for every ECG that you look at, as the modern machines will try to adjust the amplitude of the ECG tracing in order to fit everything onto one page.
Step 2 in our systematic approach is to calculate the heart rate. The heart rate of the pediatric patient varies with age. There are many different range guidelines. Heart rates are highest in neonates and infants and then decrease with age. On this slide is an example of the PALS guidelines for heart rate ranges. At birth, the heart rate can range from 90 to 205 beats per minute. This range is acceptable until about 3 months of age, where the heart rate then slowly starts to decrease. From 3 months to 1 year, a range of 100 to 190 is acceptable, and after 2 years of age, a range of 80 to 120 is within normal limits. The range approaches the adult norms of 60 to 100 beats per minute at around 12 to 16 years of age. Factors that should also be considered when interpreting the rate are whether the patient is awake, crying, sleeping, as well as if the patient appeared generally unwell, such as being febrile or is dehydrated during the time of the recording. The ECG machine automatically calculates the heart rate for you. This is shown at the top of the ECG recording and can be used for confirmation, but we also need to know how to calculate the heart rate ourselves. There are various methods that can be used to calculate the rate. These include the count-off method, the RR interval method, the 610 method, or an ECG ruler can be used. We will now look at two methods that I like to use frequently. The first one, excuse me, is calculating the rate, and this is the estimation method or the count-off method. If you presume a QRS complex falls on a thick line, you can then start to count downwards or backwards from 300. So you go 300, 150, 100, 75, 60, 50, until where you see the next QRS complex falls on a red line. This gives you a rough estimation of what the patient's heart rate is. This method, though, only works if the patient's rhythm is regular. The rhythm strip method. So to use this method, you will need a 10-second rhythm strip. Count the number of R waves, the number of complexes in that 10-second rhythm strip, and then multiply it by 6. This method is very useful for slow and irregular rhythms. So here we can see in the example, we counted that there were 28 R waves in this 10-second rhythm strip. We multiplied it by 6 and got 168 beats per minute. So depending on the age of this patient, this could be a normal heart rate. Our next step is to look at the rhythm of the ECG. Ideally, we want to find a normal sinus rhythm. This means that the electrical impulse in the heart originated from the sinoatrial node. As the sinoatrial node paces the heart, it sends an impulse that travels from the right atrium to the left atrium and down towards the AV node, resulting in atrial depolarization and a P wave being formed on the ECG. In sinus rhythm, every P wave should be followed by a QRS, and every QRS should be preceded by only one P wave. And the P axis should be between 0 and plus 90 degrees at all ages. To confirm if the P wave is indeed normal, look at leads 1, 2, and AVF for upright P waves, and lead AVR for negative P waves. This is illustrated on the slide that is currently up on your screen. Every P wave and QRS complex on the rhythm strip should also be inspected so that no arrhythmias are missed. An abnormal or changing P axis, an absent P wave, or an abnormal P to QRS ratio indicates a non-sinus rhythm. Looking at these two ECG examples, we can see that each of these patients are in sinus rhythm, as there is a P wave before every QRS complex and a QRS complex after every P wave. A little bit easier to see in the top example than in the bottom. Our next step is to assess the axis. Because of the physiology that takes place during the fetal circulation, the right ventricle is much thicker and stronger than the left at birth. In the weeks to months following birth, there's a progressive change from right ventricular dominance to left ventricular dominance. So in utero, blood is shunted away from the pulmonary vasculature, leading to higher pulmonary pressures and a relatively larger and thicker right ventricle. So right axis deviation is thus a normal finding at birth and usually resolves by 6 months of age. An easy and quick method to approximate the QRS axis is by looking at the overall polarity of the limb leads. Find the most isoelectric limb lead. I would say that in this example, it is either lead 2 or AVR. And then on your vector diagram, find the lead that is perpendicular to lead AVR, and that is lead 2, which is at 120 degrees. In this example, there's therefore a rightward axis or right axis deviation. And depending on the age of this patient, a right axis could be normal or it could be not, could not be. A very simple way to assess the axis is the rule of thumb method. To use this method, look at leads 1 and AVF. Lead 1 correlates with your left thumb, while lead AVF correlates with your right thumb. Thumbs up equals an upwards QRS deflection. Thumbs down equals a downwards QRS deflection. So as you can see in the table on your screen, we are then able to determine the axis of the ECG by using our hands. This slide shows us the mean axis values for the different age groups. This is definitely not a slide that needs to be memorized, but know that the different age groups have different axis values, so that when you do work out an axis on an ECG, you can refer back to this to decide whether it is normal for that specific age group. The next step in our approach is to measure the intervals of the cardiac cycle to look for any conduction disturbances. This section relies heavily on the norms for age, as to all the other ECG, pediatric ECG parameters, as certain intervals change throughout development. The changes seen here are largely due to the age differences in heart rate and cardiac size. I will briefly discuss how these intervals progress and which leads are best for each measurement. A quick summary before we go into each of these in detail is that the PR interval and the QRS duration are shorter at birth due to a smaller cardiac size, and a normal QT interval is slightly prolonged at birth. This is a summary slide of the various intervals and the normal ranges in an adult patient, but it just gives us a brief overview of what the definitions are of the various intervals. So the PR interval is measured from the start of the P wave to the start of the Q wave, and it is best measured in lead 2. It gradually increases from a mean of 100 milliseconds at birth until it reaches adult norm values of 120 to 200 milliseconds, which is about 3 to 5 small squares, at age 16. Prolongation of PR interval typically indicates an abnormal delay in the conduction from the atrium and the AV node, and may be seen in myocarditis, congenital heart defects such as an atrial septal defect, hyperkalemia, and ischemia. A short PR interval may be seen in Wolff-Parkinson-White syndrome. The QRS duration is the duration from the start of the Q wave to the end of the S wave and is best measured in V5. It increases slowly from 50 to 80 milliseconds at birth to the adult norm of 80 to 110 milliseconds, which is about 2 to 3 small squares, at age 16. The wide QRS duration indicates that there's a ventricular conduction disturbance, where the impulse is delayed or abnormally transmitted across the ventricles. It can be seen in right or left bundle branch blocks and in ventricular arrhythmias. So looking at the ST segment, this is measured from the end of the QRS complex to the beginning of the T wave. It is normally isoelectric in that it is flat running across the baseline. Changes in the ST segment can reflect ischemia or inflammation, the former of which is quite unusual in the pediatric population, but can occur. If we look at this example, if we look at the ST segments here, you can see that all of them are elevated. So when you see diffuse ST elevations across all your leads, you should think of pericarditis as the potential diagnosis. The QT interval is measured from the start of the Q wave to the end of the T wave and is best measured in lead V5 or lead 2. It varies with heart rate, so it is interpreted using the corrected QT interval, which accounts for the heart rate. The corrected QT interval remains relatively stable in all pediatric age groups at around 440 milliseconds as the upper limit of normal. The only exception is in early infancy, where it is slightly longer and can be up to 470 milliseconds as the upper limit of normal. A long QT interval is associated with various or serious ventricular arrhythmias with a potential for sudden death. So it is an essential part of the ECG that should not be overlooked. We use Bazet's formula to calculate the corrected QT interval. To work out this interval, or the corrected QT interval, we divide the QT interval by the square root of the preceding RR complex, that is the number of milliseconds between the QRS complex right before the QT interval of interest. Again, you have to look at the normal values to determine whether or not this calculated QT interval is abnormal for your patient. But in general, a number that you can keep in your head is less than 450 milliseconds. It's important to measure the QT interval accurately, as patients with prolonged QT intervals are at risk for ventricular arrhythmias or sudden death. On the slide here, I've highlighted for you the formula and the details of that formula, as well as some of the conditions where you would find a prolonged and a shortened QT interval, corrected QT interval. So we now move on to calculate the voltages of the heart, which can provide us with very important clues to whether there is an abnormal mass or hypertrophy. So hypertrophy of the myocardium is one of the most common abnormalities seen in the pediatric ECG. It can result from anything that causes volume and or pressure overload in the heart and can impact the atria and the ventricles. Once again, we have to refer to the normal ranges and assess if the patient falls within these normal ranges or not. So let's look at how the P wave on the ECG can help us with identifying hypertrophy. The first half of the P wave reflects the right atrial contraction, and the last half of the P wave reflects the left atrial contraction. So how do we assess if there is atrial hypertrophy? An abnormal P wave is characterized by a P wave that is taller or broader than 3 small squares. Right atrial hypertrophy is characterized by tall P waves, which are 3 millimeters or greater in any lead. Tall P waves are most commonly or can most accurately be seen in lead 2, V1, and V2. As just mentioned, a P wave represents atrial depolarization. So if we think about an impulse traveling from the SA node through the right atrium to the AV node, it makes sense that an enlarged right atrium would result in a taller P wave. Left atrial hypertrophy is characterized by a prolonged P wave, so a broad P wave, which are 0.1 seconds or longer in any lead, or longer than 0.08 seconds in infants. If we again refer back to the traveling impulse from the SA node to the AV node, if the left atrium is enlarged, one can imagine that an impulse going through both atria will take longer to reach the AV node, resulting in a broader P wave. Broad notched P waves in limb leads and a biphasic P wave in V1 with a dominant negative terminal segment may raise your suspicion for left atrial hypertrophy. Biatrial hypertrophy, so the left and right atrial hypertrophy, may also be seen, and it is characterized by a combination of an increased amplitude and a duration of the P wave, so a broad and tall P wave. Patients who have right atrial enlargement have large P waves in lead 2, as you can see here in this image. Again, the P waves in right atrial enlargement is usually greater than 3 small squares, so taller than 3 small squares. For left atrial enlargement, we look at the second half of the P wave. This gives a notched P wave in lead 2. This is usually greater than 120 milliseconds. In lead 1, this gives a biphasic P wave. Let's now move on to the criteria used to diagnose ventricular hypertrophy on the pediatric ECG. When we think of a hypertrophied ventricle, we should imagine a ventricle that is larger and or thicker than the normal ventricle, which in turn causes the forces within that ventricle to be amplified. This causes the following ECG changes. So you could have a large QRS complex in the precordial leads. You can have an abnormal RS wave ratio in the precordial leads. And the QRS axis deviation will deviate towards the hypertrophied ventricle. This is mainly seen in cases where there's right ventricular hypertrophy. It now becomes very critical that we remember which leads represent which ventricle. The right ventricle can be assessed by the positive right waves in the right side of precordial leads, so that being V1, V2, and V4R, as well as the limb leads, lead 3 and AVR. The left ventricle can be assessed by a positive R or the positive R waves in the left side of precordial leads, so V5 and V6, and the limb leads 1, 2, and AVL. An hypertrophied ventricle would show large R waves in these respective leads. The sizes of the R and S waves in these leads can also be used to assess the relative forces of each ventricle. The S wave provides insight into the forces in the other ventricle, since the forces on the opposite side of the heart record as a negative deflection. As already discussed, the right ventricle is dominant at birth, and in the months to years following, there's a progressive shift from right ventricular dominance to left ventricular dominance. If we look at lead V1 here, so infants in their first month of life should have a high RS ratio, where the R wave is greater than the S wave. This is because lead V1 reflects the right ventricle, which is dominant at that age. As the axis shifts, so too will the RS ratio. And often by 2 to 3 years of age, the amplitude of the R and S waves are equal. After 3 years of age, the ratio typically drops below 1, so that the R wave is now smaller than the S wave. The S-wave ratio, the R-S-wave ratios in lead V6 essentially shows the opposite trend to V1. So typically the RS ratio in leads V1 and V6 are used to assess for proper ventricular development. When one first looks at a pediatric ECG, one might think that all pediatric patients have ventricular hypertrophy. It's important to remember that the pediatric patient generally has a thinner chest wall compared to the typical adult patient. Because the ECG electrodes or leads are in closer proximity to the heart muscle, it can make the complexes look bigger. So before you diagnose every pediatric patient with ventricular hypertrophy, remember to never trust what the machine tells you. Do not read the interpretation of the ECG machine, as it will often over-report. You need to interpret the ECG yourself. Double check that your machine standardization is correct, as this will also affect the size of your complexes. And remember that ECGs cannot diagnose left ventricular hypertrophy or right ventricular hypertrophy. Those are all clinical diagnoses. The ECG will show you features of such a diagnosis and should prompt the clinician to investigate the patient further. Many rules have been created to help you identify complexes which are abnormally large on the pediatric ECG, and many of these rules are very complicated. Some practical take-home points I will discuss in the next or in the upcoming slides, but in this current slide that is on display, it's a summary of the values that are used to assess for left ventricular hypertrophy and right ventricular hypertrophy in the different age groups. It is almost close to impossible to remember all the values that are noted here. Therefore, know that they exist so that you can refer back to them when you are needing to diagnose left ventricular or right ventricular hypertrophy on a pediatric ECG. So, criteria for left ventricular hypertrophy. You need to look at your ECG and determine, is there left axis deviation for that age group? Are there tall R waves in V5 and V6? R waves that exceed the limits for that particular age group? Does the R wave in V6 intersect the baseline of V5? Because this is considered abnormal. Are there deep S waves in the right-sided leads, so V4R and V1? Is the RS ratio in favor of the left ventricle, and is the RS ratio decreased in leads V1 and V2? These criteria all point towards left ventricular hypertrophy. For right ventricular hypertrophy, look for right axis deviation for that particular age group. Remember, right axis deviation can be normal at birth and up to 3 months of age. Tall R waves in the right-sided leads, such as in V4R and V1. Are there deep S waves in the left-sided leads, so V5 and V6? Is the RS ratio in favor of right ventricular hypertrophy, so bigger R waves compared to S waves? Is there an RS ratio of more than 1 in V1 and V2? Is the RS ratio less than 1 in V6 after the age of 6 months? Also look for upright T waves in V1 and V4R after the first week of life. T waves can be upright in V1, but only in the first week of life and then again in adolescence. An RSR pattern where the second R wave is taller than the first R wave is also suggestive of right ventricular hypertrophy. If the patient is more than 6 months old and the ECG only shows an R wave and no S wave in V1, then this is also considered an abnormal finding. A QR pattern in V1, so a small Q wave and a tall R wave, also points towards right ventricular hypertrophy. The last step in our approach is to look at the ST segment and the T wave for repolarization abnormalities. There are several ST T wave changes in the pediatric ECGs that are considered normal, but may be more alarming if they were to be seen in an adult ECG. Pathologic ST and T wave changes are less frequent in the pediatric patients or age group because ischemic heart disease and infarction are rare in this population. Nevertheless, certain ST and T wave changes can signify serious myocardial disease, so proper identification of these changes is critical. The T wave illustrates ventricular repolarization, and the size and the direction of the wave are important indicators of cardiac function. The T wave in leads V1 and V2 and V4R are typically upright and at birth until day 7 of life, where they then flip and become inverted. They should remain inverted for the next 8 to 10 years. They then flip back and remain as upright T waves from then on. Positive T waves in leads V1 and V2 and V4R from day 7 to about teenage years of life may suggest right ventricular hypertrophy. The ST segment is the phase after ventricular depolarization and before repolarization. In a healthy adult ECG, this segment should return to baseline before the T wave starts. In the pediatric ECG, however, a slight elevation or depression of 1 millimeter in the limb leads and up to 2 millimeters in the precordial leads is common and within normal limits. We will not be discussing the details of the ST and T wave changes in this talk, but some common conditions that can cause ST T wave changes include things such as myocarditis, pericarditis, left ventricular hypertrophy, right ventricular hypertrophy, cardiomyopathy, a digitalis effect, hypothyroidism, and although rare in the pediatric population, myocardial ischemia and myocardial infarction. Another normal ST variation in the pediatric ECG is to take note of is benign early repolarization. In benign early repolarization, the leads with upright T waves have elevated ST segments, and the leads with negative T waves have depressed ST segments, and the T waves are usually taller than normal. It usually involves the inferior leads, so 2, 3, and AVF, and then the lateral leads, V4, 5, and V6. You may also see small positive deflections immediately following the QRS complex, which is called a J wave. Although it may look concerning, this ST segment shift, it is stable and it is quite common in healthy adolescents. Now, I would like to open the floor. We've got one example. Can somebody tell me what typical features of the pediatric ECG we see here? Anybody? I don't want to pick on someone.
There aren't any volunteers. I think you should.
Okay, sure. Who's on? Dana? Oh, sorry, we've gone to the next slide. Is Robin on? They're all obviously playing this in the background. Who else is there? Hashifa, are you there?
Hi, I'm here.
What do you think?
Um, just right off the bat, I do see some inverted T waves
Yes, very
in
good.
V1, V2, V3. I think you said those ones are
Yeah.
all normal in certain ages. Yeah.
Yes.
Yeah, I'm not sure what else.
Okay, so we can also see here that the heart rate looks quite fast. I mean, if you were to see this in an adult patient, you would be worried that this patient is tachycardic. If we had to work out the heart rate, I think it comes to about 110 beats per minute. But as also mentioned, this could be a normal variant depending on the age of the patient. What we can also see is that there are quite dominant R waves in V1, not so much, but more obviously seen in V2 and V3, which can still imply that there's right ventricular dominance in this patient. Or there could be right ventricular hypertrophy, just depending on the age of the patient. And yeah, that's what I would think, or those are the points that I wrote down.
So
if
if
you,
V1, V2, and V3 also, you can see the R wave progression is in keeping with right-sided dominance as well.
yes, that's
Yeah.
very true. Okay, so before I summarize my take-home points, I'd like to emphasize that there is not one single best way to interpret a 12-lead ECG. However, it is important that we as clinicians adopt an approach that is systematic and methodical to ensure that important abnormalities are not being missed. It is worth reiterating that every ECG must be interpreted in the light of the clinical information about the patient. And in the pediatric age group, the age-specific limits of normal are an essential tool to accurately assess what you are seeing on the ECG. So now for my take-home summary points. It's critical to understand which leads represent which part of the heart. Remember to use the ECG in combination with an excellent clinical history to aid you in finding a small clue to a very important diagnosis. Have a systematic approach so that you do not leave anything out. And practice, practice, practice. The more you are going to look at ECGs, the more ECGs you are going to do in patients in the ED, the more comfortable you will become with interpreting them. So here is a little cheat sheet that I found on Do Not Forget the Bubbles website. This cheat sheet is also available in our ED protocol book. It highlights the important steps that we have discussed during this talk that need to be taken to interpret a pediatric ECG correctly. I also found another little cheat sheet, and this was from the Peds Cases podcast. I think we should also maybe put this into the protocol book, Tammy. It's similar to the previous one, but it has a little bit of more extra information. And it is a very useful resource to have in your back pocket when you are interpreting ECGs. This is a very brief 5-minute video that shows all the important aspects of the pediatric ECG and can be found on the EMN5 website. She does speak very, very fast and goes through basically what I've done now in 47 minutes, 45 minutes, in 5 minutes, but it is a nice little video to watch. So that's me. Thank you very much. And we can now open the floor to any questions.
Sorry, man. Can I ask a question just with